Terrific. That was really great. So the rule of the game is if you want to ask a question, get the discussion started. You go up to the mic, say who you are. And it's an august setting, but this is us, and it's our home, so just get up there and talk. Who wants to be first? Where's George Kaplan?
You're on.
Yep. My name is Deborah Helitzer. I'm from the University of New Mexico in Albuquerque, and I'm proud to say that we just got approval to start the first College of Population Health, with the second in the country, Jefferson, and to respond to your calls for a new workforce, the first bachelor's of population health in the country. Thank you. So I'm very excited because I really feel like we are going to try to do what you've asked for, which is to develop a new workforce. And we have tremendous collaboration from all of the different colleges, architecture, business, engineering, actually, social sciences. So, and the healthcare system. Part of the training will be population health management. And so I'm very excited about it, and I'd love anybody's suggestions about it. In particular, though, I wanted to ask Dr. Hayward to talk about resilience. So one of the things you showed is that childhood adversities, the greater the adversities, the higher risk, obviously, total health, right? And I wonder whether you're thinking about resilience as part of the motivation or part of the characteristics of someone who has very high childhood adversities, but nevertheless gets to achieve a higher educational attainment. So have you thought about that?
We've thought about it, but I can't tell you that we've directly addressed the resilience idea. One of the things that doesn't come through in some of this work are the nuances, and let me give you an example. So in today's world, we think that the reason that our kids do so well in school or don't do so well, it's all the parents, right? It's really about us, the parents, and how much we push our kids or don't push our kids. And so we have this kind of upstream parental education and whatever their characteristics are working through the kids' education. And so that's how most of us tend to think, and it's a quite now perspective. In the data that we're looking at here, most Americans have forgotten that we ran the largest natural experiment in the history of our country pretty much, which was we expanded post-secondary education. So we had a bunch of kids that should have never gone to college in the years before, and yet the expansion of those time periods allowed us to kind of have this real fresh look on how it is that the early life disadvantages combined with later life education, as an example. And so we can get a quite independent take on this. I'm not going to run that experiment now. It's not like we have a lottery that says, okay, I have all these kids that have come out of childhood, these are the backgrounds. Now I'm going to run a lottery in terms of what kinds of adult experiences they get. We simply don't run that lottery. But in the United States, we did something that was quite unusual and we forget this kind of historical context in which these kinds of data come out. I mean, I'll just be quite blunt. If I were to run this again in 20 years, I'm not sure what the results would look like. I do have a sneaking suspicion, however, that the role of education is going to be even greater.
We'll take you by the order that you came up, so go ahead.
Thank you, Bruce. I'm Mike McGinn from the National Academy of Medicine. First, a really hearty thanks and congratulations to the speakers. Congratulations because of your contribution to the inaugural event here, which is really momentous in many ways. The descriptions and visions of science and practice and policy that you laid out are really exciting. I've got a question for Jeff. Among the exciting things you talked about in the policy arena, you mentioned two in particular. One, the notion of accountable communities in many ways, and the interest and willingness of CMS to get behind it. And secondly, the announcement of IRS, virtual announcement, that they were a public health agency. So
They wouldn't say that.
I know they wouldn't say that, and that's why I'm raising, that's the question I want to throw to you. They could have a tremendous power, especially if IRS and CMS got together to lay out the strategies and approaches at the community level for linking community benefit with accountable communities. What do you see as the prospects, first in IRS, for that, for them to move into a more aggressive approach, and secondly, for the linkages?
So I guess I'm not convinced that IRS will take a more aggressive approach, and some of that is not for the wrong reasons. I think they feel ill-equipped to have the expertise to be able to judge whether a hospital is engaging in something that is indeed, improving the public's health in a way that experts might conclude. I think they've become more and more flexible in counting things like community building as part of community benefit. I think the solution on the community benefit side is, and this will get me to accountable health communities, is severalfold. One is transparency, and the Robert Wood Johnson Foundation is supporting the George Washington University and others to build a database of everyone's investments, so it will be a searchable database so communities can see how hospitals are investing their money in community benefit and can compare them to like hospitals in other communities. And so that provides an opportunity for advocacy and collaboration. I think it's also a question of leadership where, in Seattle, King County, the local health department brought all the hospitals together and said, we're going to do a common community health needs assessment. That's happening in a few other communities. And so you're creating those relationships. But then how does that relate? How do accountable health communities come together with community benefit? And I think that's where we need to be thinking about sort of a new structure that will allow people to come together to better coordinate the multiple investments that are happening in a community. And so the California Endowment and several other funders in California, only to make life, this is going to be very confusing. So CMS is doing accountable health communities. California Endowment is talking about creating accountable communities for health. And part of that would be the creation of a wellness trust that would provide resources for communities and would create a mechanism for communities to bring together things like philanthropic dollars, community benefit dollars, and even perhaps braid together some of the government money that is coming into a community and making sure it is working in tandem and in a really coordinated way. So I think that may be one way of getting the accountable health community concept and the community benefit concept to come together, is to have that mechanism to provide additional support. There is nothing in the accountable health community concept that CMS is talking about that would prevent that backbone organization or that bridge organization to also reach out to hospital community benefit programs and say, we've identified some gaps here that CMS won't pay for, but you could with your community benefit dollars. So I think there are various ways of making that work.
Can I add one thing, Bruce? It's important to recognize the bright spots. It's also, I think, educational to think about how much floundering there has been from the hospital community. When the IRS regulation, new kind of Schedule 990 came out, many hospitals, particularly those not in places like Seattle, King County, or San Francisco, or places where there wasn't as much infrastructure supported to population health and public health, many hospitals were just like, what the hell is that? Like, what do we do with that? And there was quite a bit of backlash about like how could we do this, and very little guidance that helped people understand what a community needs assessment was, community health needs assessment was, and how to go about addressing it. And so I think what we've seen lately is sort of increased guidance, but I don't know how much uptake we've had. And I definitely think there's room for population health researchers to influence that process.
Underscoring the comment that was just made, this is an opportunity for population health science. I raised the issue in part because I'm on the board of a hospital system, and I watched them spend $1 million for a community benefit assessment, while the same system or the same assessment was going on across the town. So that's really what I was referring to, Jeff, and talking about more assertive IRS guidance to get people working together. And I do think there's a strong role for the population health community to get involved and help make that happen and take advantage of the resources that are invested.
Okay, we have a bit of a dilemma, and that is that we're bringing up issues that are super important to discuss, but we also have a lot of people on the floor. So make a norm of a little shorter question, little shorter reply maybe, so that we can get everybody's questions in. My counting has 4 people over here, and then we'll turn to the 2 over here in terms of the order.
Robert Brook, I'm going to make one short observation and one short question. The observation is we failed in health services research in the last 50 years because we didn't trust the community and we talked to them. When I look around the audience, there's very little diversity, and I don't see the community actually here that's going to be impacted by this. I would suggest that that gets changed at the next meeting. I also would suggest that you would pay $1,000 registration fee if you don't bring a community member with you to the meeting. I'll add one other part. It's amazing what the for-profit sector is doing now in the country in this area, and that excluding them would also be a mistake. Now for the question. There's a book that just was published on the economist Nobel Prize laureates' assessment of what to do in the developing world to improve health. They argue strongly for focus. And given the Barker hypothesis and the opening speech, why don't you all recommend that we put virtually all the resources into the first 2 years of life and apply what we know, because 90% of the health trajectory is determined by that short window? And why are we doing anything else until we fix that problem in the United States?
That's you, Mark.
Because they're wrong.
Yeah.
That's a short answer. They're wrong. I mean, if you looked at the evidence I just presented up there in terms of the role of education and the contributions of adult factors, yes, early life is really important. But there are many, many points of intervention over the life course. It's not just the Barker hypothesis. We're not talking determinism. We're talking probabilistic. And so you can't ignore the other kinds of exposures that come after life. And if you want to see up here, I can show you the slides again. I know they would disappoint Jeff. So I really don't want to show those slides again about how long you would live in a healthy life based on years of education, but that, those are kind of social interventions and changes in our societies, giving them enough human capital, social capital, and physical capital. Those things increase the quality of life, and they have enormous benefits far beyond the Barker hypothesis.
Okay, next.
Anna Diaz, Drexel University. So I started my career as a physician, and I was a pediatrician, and we worked very closely with social workers and legal aid. This was in another country. And maybe we didn't do it that well, but one of the reasons I got into public health is because I felt that there was so much that the healthcare system just could not address. And so it's very interesting to me to see now this, the healthcare system in this country sort of rediscovering the social determinants. And I think it's great that there are all these efforts to think about how clinical practice can link to a range of other services to help address some of the social determinants. At the same time, I think it's important for us to remember that this is a very service provision-oriented approach and individual patient-oriented approach. And that's great, but I'm skeptical that it's really going to be able to make a big dent in the bigger factors out there that are driving the population health patterns. So I think it's very important, but because we're in a population health meeting, I think we have to remember that there are going to be very important limitations to that approach. And also, it troubles me a little bit that not in this panel, which I think was terrific, but sometimes in the conversation, there's this implicit idea that we're trying to make the healthcare system now responsible for things outside the healthcare system. And I think, it's not fair to the healthcare system because it's not what it was really trained, and it should be trained to do. It has another very important mission, which it needs to do really well. We all want it to do it very well. And second, because they just can't. And we get these things like Mike was mentioning. They're doing community health needs assessment, and you have a public health agency doing a similar community health needs assessment in the same city. This happens in Philadelphia, for example. And so we really need to incorporate and recognize and welcome this opening of the clinical world to social determinants, but at the same time, remember that there's a lot of other stuff out there which the healthcare system cannot address. So I think there's a little bit of a tension that we just have to be careful as we have this dialogue between public health or population health and the clinical world, which I think is terrific and provides lots of opportunities for population health.
Lori, you want to respond?
I mean, I respond by saying I agree completely. So this is a small piece of the puzzle, but it's a critical piece of the puzzle. So I think by ignoring the role of social factors in the context of healthcare delivery, we end up driving up our costs, spending a tremendous amount, sort of it's like chasing your tail. I mean, that's why I left clinical practice, right? Is that I felt like I wasn't making any headway on the underlying factors that were making the kids and the adults who are coming into clinic unhealthy. So it's a combination. We have to be able to identify and address social needs in order to decrease the later healthcare costs, the existing and the later healthcare costs, but we certainly are better suited to do a lot of that intervening and a lot of the upstream work outside of the clinical setting. And so I would say this is work that has to move forward on both fronts, mostly outside of the clinical setting, but our healthcare partners really need to be engaged as real partners.
Two very quick points. One is, I agree with everything you said, and I think we've all said we don't want to healthize everything. A lot of the ACA investments in prevention have really been about policy and systems change. The most powerful advocates for some of those policy and systems change can be people coming from the clinical setting because of the respect with which they are held, the way doctors are regarded by policymakers. And I guess the third thing I would say just is also that while policy and systems change is always perceived as more upstream in the delivery of services, having housing is a social determinant of health. And you provide housing to people one home at a time. And so you also have to be providing that link to the social services. It can't just all be perceived as policy and systems change, and once we get into that dirty stuff of actually talking to someone one person at a time, somehow that's not a good thing.
I'm going to violate Bruce's, I'm sorry, I have to say one other thing. I actually have really found in the healthcare system that the conflation of social determinants of health and population health is tremendous. So people talk about social determinants of health as if it were population health, and obviously to people in this room, we know that it's not. So we're doing social determinants of health as one way to help pull in data and better understand what we can do to address or to improve population health, but that's still it's downstream, individual, targeted. But if we do it right, it informs our population health efforts. So I just we need to do a lot of work around distinguishing between social determinants of health and population health in the healthcare system.
So I have 10 minutes and 5 people up, 2 here, 2 there, and then the last person. We'll shoot to get to you, but it'll depend on this discussion. Go ahead.
Good morning. My name is Stephen Thomas. I'm on the faculty at the University of Maryland College Park School of Public Health. And on the workforce issue, we're actually entering our first class of graduate students in a new MPH degree in health equity. I say that because some of the issues around sustainability take different shapes and forms, and I don't know if you're even looking at some of these institutional changes that are occurring that I would put in the category of sustainability. That's number one. Number two, we didn't get into this situation overnight. But there seems to be a sense of urgency, even from this panel, that we somehow have to have the data proving what we're doing works now or tomorrow. And I'm a bit concerned about that, given the hurdle ahead of us. So if we are the choir, and even choirs need practice, I'm not hearing from you, what is that loyal opposition putting out there that we have to be able to respond to? What are, we come into meetings like this, I leave great, and then I hit the blowback, and I don't have the answer. You can help us, but here is the opposition, here are their arguments, here's a response. Without that, we're not singing off the same page. We have to name names. So who is that opposition? Who doesn't want our populations to be healthy? We got to name names. And you need to help us know who that is, because they might be at the same table we are, pushing in the wrong direction. Thank you.
Where's the spider in the web of causation?
For starters, check out the sponsors of the reconciliation bill in the House of Representatives.
Hey.
Hi, I'm Amy Martin. I actually have an invitation and a research question. So I'm director of a new division of population oral health in the College of Dental Medicine at the Medical University of South Carolina. We would love to host everybody in the room in 2018 if we could add oral health to the agenda somewhere. I'm also affiliated now 10 years with our state's Rural Health Research Center. We're one of 7 funded by the Office of Rural Health Policy. We're tasked with doing secondary data analysis, exploring many of the issues already discussed. You're asking names in opposition. I'm going to throw CDC under the bus. So we're finding that there is a huge cry for population research. The juxtaposition is it is becoming ridiculously more expensive. The sample sizes are changing and shifting more to urbanized samples. And unless you're a university that has a contractual arrangement with the National Center for Health Statistics or a ResDac engine, getting access to data while those researchers are mining it, getting their own pubs out, is becoming more and more difficult. This is my sermon, I'm so sorry. So I don't know if this is the forum to have this policy discussion, but we need a better, fairer policy so we can access the national data to conduct the research you all are requesting. And so I would love your response, feedback on your own challenges and what you think those rules ought to be.
Anybody want to say?
Talk to your colleague Katrina Walsman in the School of Public Health.
Yes.
She's a great resource.
I mean, I couldn't agree with you more about some of the barriers that we have, not just in accessing data, but also in accessing the results of government-supported research, and that sometimes those who are overseeing that government-funded research are more interested in waiting till it's published in the right peer-reviewed journal than getting it out there in a way that can be used in a meaningful sense to direct how programs and policies are changed. And that is certainly something this organization could take on.
That's what I wanted to hear. Thank you.
Back to this side.
All right, my name is Sherman Wilkins. I'm a PhD candidate at Penn State in sociology and demography. And first and foremost, thank you for great talks. My question's for Dr. Hayward with the relationship between education and this active life expectancy. Maybe if you can touch a little bit more on racial and gender differences. Or even better yet, the intersection between race and gender, maybe those things, maybe it operates differently. And the other point, is about the relationship and whether it holds now. I mean, given increasing student loan debt, sluggish economy, is education still this really big boost that we've seen in the past?
So I will tell you that the effects of education on mortality, which we know my team has done quite a little bit of work on, has shown that education over the course of the latter part of the 20th century has become increasingly important in reducing mortality. And in fact, we've never seen anything like it in terms of how much mortality risk declines by each additional year of education. And this has been continuing throughout the later part of the 20th century and has been accelerating into the early 21st century. Now, don't think that these effects are exogenous. We live in an environment in the United States in where we have a lot of things out there that require advanced education in order for us to garner these health advantages. At the same time, don't forget about the people at the other end of the spectrum, which are the left behinds. And if we live in a fast-paced, technologically oriented, information-rich environment where we need a lot of these resources to garner health advantages, we have some left behinds too. So the gradient has been fanning out as the pace of social and technological and institutional change has happened. What I showed you is quite endogenous to this larger processes of historical change in the U.S. We're just beginning to document this kind of thing. You ask about race differences, and I think one of the most fast-changing things that's going on in the United States right now are race differences in health, but not as we would think about them. We've often thought recently that the kind of, that men's mortality, black men's mortality would really never kind of change, and because we have a lot of risk factors that are going on in the African American male community. But the actual truth of the matter is that we've seen enormous gains in life expectancy among the black male population in the last 10 or 15 years. And the gains are coming at all ages, and if you look at where the gains in life expectancy are coming across the different educational groups, it's really impressive in them kind of massive gains that are occurring. So even at the kind of low education levels, where they're coming in the age spectrum. So I caution us to not think that anything that I've shown you or anything that you will see is actually a kind of set in stone set of issues. So that's the one thing, because we tend to think about these kinds of individual risk factors as being exogenous. They're not, right? They're really quite endogenous, but we don't think in them because we're quite myopic in our own worldviews.
Okay, thank you.
Hi, I'm Julia Lynch. I'm a political scientist at the University of Pennsylvania. Well beyond the dissertation writing phase, Jeff, but I want to take you up on your challenge to sort of think about the politics of the National Prevention Council. And I'm particularly interested in why it's called prevention and what that choice of language tells us about what the focus might be. So I wondered if you just have any insights into why that particular language was chosen and what impact you think it might have on the work of the council.
So I think the council has, through the strategy, defined prevention in a very broad way. But that is where messaging research can be very helpful. We've, at TIFA, done a lot of messaging research over the years. No one understands what population health means. So when we think about policymakers, we should think of average Americans, because to some degree they are thinking in similar ways. And this is going to get to some of Steve Thomas's questions as well. They don't know what public health means. They don't know what population health means. They like prevention.
What?
And even though prevention may mean all sorts of things to all sorts of people, the concept of prevention and that there is a government role in prevention is accepted. Now, then there's disagreement about what is the government's role. Is it to just give me the information and then I go do with it and not have the government telling me what to do? Or is it the government creating an environment where it's possible to make things work? The progress we have made in talking about these things is people understanding that what happens outside in your community can be as important as what happens in the clinic. So that's a real, that's not saying population health, but that the concept is understandable, and that language, I think, helps a lot. Where there is still this divide is at what point does the government provide help in addressing these things? And that's where our political divide is, and you see that in the presidential campaign, and you see this around policy decisions in this area. One way of addressing that is to talk, in terms of the creation of these programs, is really empowering communities, because people have a lot more faith in the decision-making that happens in their community than decision-making that happens from Washington. And so if Washington is providing, or Baltimore, is providing the opportunity for communities to do things that create a healthier environment and healthier opportunities, I think people will embrace that. They're not necessarily we're not going to necessarily find common ground in the near future about the specifics.
I want to make sure we get our last question, and maybe you guys can, if you want to talk more in the break, Yes, please.
Hi, I just want to say thank you so much for having us. My name is Nicole Baltimore. I'm from Tallahassee, Florida. I am also a doctoral candidate at the Institute of Public Health at Florida A&M University. Really want to make a quick comment. I feel that I've had the best of both worlds as far as being in the community and in the clinical experience. I'm a physical therapist by trade, and I've done a lot of home health in rural communities. Going back to what you said as far as getting out into the community, one thing I know our school does, which is the reason I went there, is to mobilize the communities. And I really think it's important for us, if we have practitioners, whether it's physicians, physical therapists, to get out into the community and work with patients, because you can encompass that and see what's needed more so when you're out involved, because I'm the one who will call social workers or the fire department to look at a house, or have to get somebody moved out of their house because it's dilapidated and falling apart. So I think getting from behind the desk and out into the communities to see what's really needed in the communities, I think that's just very important. And so thank you so much for having us.
Thank you.
A quick comment about that. So we've done some work to show that it's for pipeline development and for health professional education, it's not enough to just teach about social determinants and health disparities. You actually have to have some practical experience, and it's a wonderful example of that. So thanks for sharing it.
Okay, our time is up. I want to thank the audience for the great questions. I bet you have a lot more. Please engage the panelists and yourselves. But to finish, let's give one more round of applause for a great talk.